We present the case of a 36-year-old woman with the following gynecological surgeries. She underwent a transobturator tape procedure, requiring excision of the mesh due to extrusion. Subsequently, she underwent laparoscopic sacrocolpopexy, which also required removal after extrusion. After the excision, the patient developed severe stress urinary incontinence. An artificial urinary sphincter was implanted. The first step consists of the dissection of the vesicovaginal space. This allows direct visualization of the posterior surface of the bladder neck, minimizing the risk of inadvertent injury. In this patient, the dissection of the vesicovaginal space was hindered by the presence of the mesh from the previous colposacropexy, leading to a traction-related bladder injury that later became evident. The second step of the surgery consists of the dissection of both laterovesical spaces up to the endopelvic fascia. Subsequently, the anterior surface of the bladder neck is dissected, attempting to preserve as much length as possible of the pubovesical ligament. Although this step is usually performed without difficulty, in this case, there was some adherence to the pubis due to the previous Remex procedure. The next step consists of connecting the vesicovaginal space with both laterovesical spaces, marking the created pathway with tapes to facilitate the subsequent maneuvers. We recommend performing an intraoperative cystoscopy after this step to rule out any inadvertent injuries, particularly involving the bladder neck. The measuring tape is passed through the 12 mm hypogastric trocar and advanced from the left laterovesical space to the posterior surface of the bladder neck. We recommend using a beaded suture at its tip to facilitate traction. The beaded suture is then secured to the gauze tape on the right side with a hemolock. This maneuver allows the measuring tape to be guided into the right laterovesical space simply by pulling on the gauze tape. Bladder neck measurement was then performed. In this case, it was 7.5 centimeters. The cuff is introduced through the 12 mm hypogastric trocar. It is then tied to the distal end of the sizer to facilitate its placement across the posterior surface of the bladder neck. The reservoir is introduced and placed in the right laterovesical space. Both connecting tubes are then externalized through the right iliac fossa by blunt perforation of the epineurosis. The reservoir is subsequently filled with 20 cubic centimeters of a saline contrast mixture. The laparoscopic phase of the surgery concludes with closure of the peritoneum. The activation button is placed by blunt subcutaneous dissection from the suprapubic area to the right labium majus. The connections between the cuff, the activation button, and the reservoir are established. No postoperative complications were reported after device activation. The patient remains completely continent and does not require any pads.